we've got ourselves a Q&A going on. So if you have anything to add, then please feel free to. Oh, got some wave to get involved. Q&A with. I mean, I bet you think I've got someone to type this in for me, but no, I have to do it myself. Man of the people, yeah. So I don't know if this is actually live on TikTok. Oh, okay. Got a maximum character limit. I think. Oh yes, Facebook's live. Hello, Facebook and YouTube. So if you've got any questions, you can post them. Add topic. Oh, not add topic. I'm just going to go live. Oh, I haven't stood up. Right, Jackie's here. Good old Jackie. You all right, Jackie? Nice to see you. There we go. That's not a good angle, is it? Right. So, got some questions here. Slightly dubious questions, but that's you know what? I'll take what I can get. I'm not complaining. Any question is gratefully received. So thank you to those members of the public who've submitted questions this week. And if you think you can do better, don't sit at home and complain about the questions. Get out there and start asking. You know, I'm not saying there's anything wrong with these questions. They're good questions, and I'm very grateful to the people who've asked them. But you know, if you've got your own question, then feel free to chip in. So the first question is, I was wondering, is radiofrequency or ThermaVein therapy a good way of getting rid of moles? Now, I've got to be honest with you, I've had to just now Google ThermaVein therapy. So I don't offer either of these treatments, and so you're probably better off speaking to someone who offers the treatments, because you know, it could quite rightly say I'm biased because I don't offer it, although I do know about how to remove moles. So ThermaVein seems to be, I'm not sure if it's some kind of laser, but it's obviously, including the title, something to do with veins or like red things. So I think ThermaVein might be good for specific type of lesions, like red lesions. So not strictly speaking, moles are kind of brown. Red things are more like things like Campbell de Morgan spots and little angiomas and little vascular lesions, which might be thought of as moles because they're kind of skin lesions. But I don't know, and if there's any ThermaVein practitioners out there, please correct me, but I don't know if that would be something that would be useful for a brown lesion, as in a traditional mole, you know, a melanocytic nevus, or a traditional mole. So it might be good for red things, but I don't think it's good for traditional brown moles. But if you have a vascular lesion, then maybe ThermaVein is good for it. I don't know anything about it. I don't use it, so you're better off talking to someone who uses it for an opinion on that. But I'm not sure if it's appropriate for brown things. Radiofrequency. Now, radiofrequency is kind of like a skin tightening technology. They've moved into fat removal or non-surgical fat removal. I didn't know radiofrequency was kind of like an ablative technology. Basically, in terms of removing moles, you need to kind of deliver energy, I guess, or destroy, if you like, that piece of tissue where the mole is. And there's lots of ways of doing that, delivering energy. People talk about lasers, and you can get a scraping thing, or you can cut it out with a knife, or or acids. People use acid, and you know, there's lots of ways of delivering that energy. So people talk about laser. I'm not sure about radiofrequency for moles. Again, if the person asking this question presumably has found someone who offers these things. In which case, if you found someone who offers these things, I would ask them kind of pros and cons. But in terms of energy delivering methods of mole removal, yes, they are out there. So are they a good way of getting rid of moles? In my view, only in limited situations in terms of energy delivering mole removal, and that's kind of like multiple moles. You've got multiple moles and maybe a laser or something that can take lots of moles off. The problem with these kind of ones is that you can't send the mole for histology. You don't actually kind of remove it. You kind of destroy it with the energy, whether that be a laser or whatever. It's kind of burning it, if you like. So that's one point, that you can't send it away. The other point is the level of energy that you're delivering in order to remove the mole. You've obviously, well, maybe not obviously, but you've got to deliver enough energy to remove all of the mole, so deliver the thickness of the mole to destroy the whole lot of it. Because if you don't, then when it heals, you could be left with a mole still there, a kind of brown thing still there. But if you deliver too much, then you end up with more scarring. So it's a balance there, and it's a balance that is difficult with these energy devices. And I do it with a knife by cutting them out, which you could, and sometimes people say, oh, a knife scars, and laser or something like that doesn't scar. Well, everything is going to kind of leave some kind of mark, call it a scar, whatever. The fact of the matter is, often things scar so well it doesn't look like a scar. So that means that people think that we don't leave a scar, and you can do things with a knife. You can cut things out or shave lesions, and the scar is really hard to see. And people say it hasn't left a scar. Well, it has left a scar, but it's often quite hard to see. So they kind of think that it hasn't left a scar. And the same can be true for the energy devices, but you have to get that energy delivery right. And so really speak to someone who offers it to see what they think the pros and cons are, look at some photographs, some before and afters, and swipe. So personally, I don't recommend an energy device like a laser or what have you for mole removal. I didn't know radio frequency could do it, but if radio frequency can, great. I didn't know ThermaVein can do it, although I think that's, as I say, talking more about vascular lesions. For vascular lesions, that's different. I think for a vascular lesion, for a red thing, I think using an energy device like a laser is perfectly, absolutely, totally reasonable, because in those circumstances you can use a device that will target the red pigment, selectively target the red pigment, and that can or not pigment, the blood vessels, basically the blood cells, not the vessels, the blood cells, and so that laser is good for red things, for vascular lesions. Laser is a very well well regarded treatment, but that's kind of different because it's not something you want to particularly send off for histology, because often vascular lesions, you can tell they're vascular lesions rather than anything to kind of worry about, like a mole. So a red lesion is different to a brown lesion. If you've got a brown spot versus a red spot, you wouldn't be as worried about a red spot, although you've got to always look at these things on a case-by-case basis. But as general terms, vascular lesions are less likely to be cancerous than a mole. With moles, we're always thinking, could it be a skin cancer? Although you can get kind of red skin cancers like SCCs and BCCs, which are kind of red things, but they're not vascular lesions. Oh God, right, okay, I think I'll stop there. A vascular lesion, the bottom line is get a doctor to have a look at it, and they'll tell you whether they think it's a vascular lesion or a mole. Crikey, yeah, because vascular lesions tend to be kind of flat, and you can get kind of red skin cancers, but they tend to be raised, and things like BCCs and SCCs. Crikey, that turned out more difficult than I thought. Okay, let's go to the next question. What is a difference? Just one. What is a difference between a plastic surgeon and a dermatologist? So yeah, the thing about plastic surgery is that there's quite a range of specialty or subspecialties with plastic surgery. When you do plastic surgery, you kind of can go down different routes. So you can go down skin, breast, head and neck, cleft lip and palate, hands, burns. So there's different areas. And when you go down those areas, there's often other kind of type of doctors that do a similar thing to what we do. So if you go to breast, for instance, there's breast surgeons who also do the reconstructive side of things, same as what plastic surgeons do. If you go down the skin, there's also dermatologists who do a similar thing to what plastic surgeons do. So there is a kind of overlap in terms of treating people with skin lesions with skin dermatologists and plastic surgeons. So dermatologists have gone down a different training scheme. Dermatologists are physicians. They've gone down a medical route as opposed to plastic surgeons who've gone down a surgical route. And dermatologists are much better at, dermatologists will see people who've got problems with skin, globally skin problems, so skin rashes, skin diseases, if you like. We don't really treat those. Dermatologists are very good at treating those, and dermatologists are much more involved in medical treatments of skin lesions and skin diseases. So topical kind of ointments, creams, tablets, oral, like acne and things like that. When you get into treatment of those sorts of things with drugs, that's where dermatologists really get involved. Plastic surgeons, by and large, certainly speaking for myself, kind of we do surgery. We cut things out. Now dermatologists also cut things out, but we kind of only cut things out. Or as I say, as myself, a plastic surgeon, I will kind of just cut things out. That's my forte, cutting things out. And often we'll get situations where dermatologists will, often dermatologists are kind of like the first port of call for things. We'll see things, and then if it needs cutting, well, so I would say they will often cut a lot of things out themselves. But if it's a big thing, or if it needs some kind of, reconstruction in some way, they will then refer it to us for the for that side of treatment. And there's a variety of dermatologists in terms of how much they'll do. Some will do a lot of surgery, some will do less surgery. I think most dermatologists do some surgery. And as I say, as it gets bigger, some dermatologists will hand it off. And we also see people directly. Certainly in my practice, I see a lot of people directly. In terms of skin lesions, moles, lumps, bumps, you can come directly. But a lot of the things I do potentially could be treated by both, could be treated by a plastic surgeon and a dermatologist. So there's a group in the middle where both kind of like your moles and cysts and what have you will be treated by both plastic surgeons and dermatologists. And then on either side there's stuff that will only be treated by one. So for instance, if you have skin lesions, if you have an underlying problem, like sometimes people with cysts have got very acneiform skin, have got like rumbling infection and within their skin, and multiple cysts and multiple problems, then you might be going more down a dermatology route. Certainly things like skin rashes and what have you, that's more of a dermatology route. So that would just be a dermatologist. And then at the other end, maybe bigger lesions, skin cancers in maybe difficult areas that might need a bit of reconstruction. That might be just down a plastic surgery route. But there's quite a large group in the middle that is treated by both plastic surgeons and dermatologists. So, and if you're, you can go, if you've got a skin lesion, you could probably go and see either. And if you were more appropriate for one or the other, most dermatologists have got plastic surgeons they work with, and most plastic surgeons got dermatologists they work with, so they could always refer you to the whatever, the plastic surgeon or the dermatologist if you're more appropriate for that specialty. So as I say, most people with kind of skin lesions are certainly a solitary lesion, a solitary lump or bump, or a couple of lesions could be treated by either. If it's kind of widespread, or if there's a extensive changes, then maybe a dermatologist would be more of a appropriate. If it's big and in a functionally sensitive area like the eye or nose or ear or mouth or lip, then maybe a plastic surgeon would be more appropriate. So yeah, a bit of both. Well, here we go. Another question: do we offer mole checks at our clinic? Now, yeah, I mean, one of the big things about what I've tried to do with the clinic is I try to avoid people having to come to the clinic for a consultation. So you can send a photo, and you can say a lot from the photo. You can't say everything from a photo. There's no substitute for an in-person consultation, but you can certainly get an idea. So in that respect, if you're kind of worried about a mole, so it depends on what you mean by mole check. So if you're worried about a particular mole and you want it checked, then you can just send us a photo. We'll have a look, and obviously you're welcome to come to clinic for, you know, to have examined. But often you can tell a lot from a photo. If you're talking about mole checks, as in you're not really worried about any moles, but you're just worried in general that, you know, about moles sort of thing, if you have a family history, or if you've got a particular thing that you're concerned about moles, we don't really, that's more of a dermatologist thing. So a kind of mole check, as say someone who's like turns up and say, look, just check my moles, and things like serial photographs and things like that, that's more a dermatology side of things, that sort of service of mole checks and following up. Whereas if you've got one mole that you want to have checked, then we can definitely do that. And as I say, we can often do that with a photograph, at least a photograph to start with. And if we're worried about it, we'll ask you to come in and we'll have a look at it. But if you're just generally worried in general terms, then that's more of a dermatology thing. We don't have a thing where, you know, if you phone and say, do you offer mole checks? We say, look, if you've got a mole that you're worried about, if you say no, we just want a mole check, we'd probably say to you, look, refer you to one of the dermatologists locally, rather than ourselves. We're more about doing things to specific things. You know, we're looking at specific moles and say, look, that looks okay, or that looks a bit of a worry. Let's get it looked at. I think that's adequate. When should I worry about my mole? Right. Okay. So the main thing, and this comes back to the mole checks thing, a lot of times, to be honest with you, in terms of the mole checks, I'm not, you know, fine to have a mole check if you are kind of a high risk. Say hi. I can say hi to people. The main thing about mole checks is, sorry, no, when should I worry about my mole? Yeah. So the thing about checking moles is that the fact of the matter is, most people who have a problem will know about it. And I'm not trying to say mole checks aren't good, but it's often the case that if you kind of haven't got anything you're worried about, it's unusual to find something that you didn't know you had, in terms of it being a skin cancer, which is kind of what we're talking about here when you're saying, when should I worry about my mole? Let's face it, we're worried about cancer. Most situations of skin cancer, the patient has noticed something. It's unusual for them not to have noticed something. And the thing that you're noticing, if I could put it in one word, is change. I guess that's the one word. But if I can put it in more than one word, which I shall also do, it's you're looking for a change in color, darker or lighter, so either way, size, bigger or smaller, again, either way, any symptoms, so bleeding and itching are the two big ones. Any bleeding, any itching, variegation of the pigment, so instead of having like a uniform pigment, if there's kind of darker patches within the mole or lighter patches within the mole, you want the edges to be quite distinct. If the edges are a bit blurred of the mole, that's a bit of a worrying sign. Sometimes if you get some depigmentation around the edge of the mole, it's called a halo, that's a bit of a worrying sign. If you get any little moles around the mole, known as satellite lesions, again, these are all worrying signs. I'm not saying they're cancer, I'm just saying they're worrying signs. So these are sort of things we're looking for, but we kind of need to put it all together to look at the mole. So any one of those things doesn't necessarily mean it's a cancer, or you could have more than one of those things, and it doesn't mean necessarily that it's turned cancerous. What it does mean is you should get it looked at, and you should worry about it, I guess. So a change is the answer. If you, and that's why mole checks are great and fine, but often, as I say, we probably, you know, it's very rare to find something that you didn't know about, and it's just looking for a progression. So it's looking for a change from where you are. So if a mole changes, because often we will look at you and it'll look fine, but you might say, well, that wasn't like that before, that's changed, and then that will make us think, oh, that's a worry then. So if you just look at it in itself, it might look okay, but the history is important. So so it's up to the patient. So often in terms of follow up, I mean, I will always follow people up in terms of, even if it's a benign mole, I'll follow you up. But in terms of the NHS, with cancers, often, even if you've had a skin cancer, they often won't follow you up because they know that if people have some new problem or something else crops up, it's more than likely to present itself. They'll know about it. So they don't need to keep on seeing patients every so often, because that if something crops up, the patient will know about it. We used to do clinics when I was in the NHS, of follow-ups of skin cancers, and months and months and months, year, 3 months, 3 months, and again and again and again, every 3 months, then 6 months, then yearly. And I don't think they do that anymore, simply because they found that they're not that effective. Because when you do see someone, if there's something wrong, they will know that there's something wrong. So we very rarely pick anything up. So it's about educating patients to let them know what to look out for, so that they can come back even when there's a problem, which is much more effective than actually bringing people back every 3 months, because something could crop up in a month or 2 months. So you should come and see us when it crops up, rather than waiting for your follow-up. Although I do offer follow-ups, because some people like that sort of that peace of mind that it's coming up. But yeah, a change is what you're looking for in your mole specifically. What's this? I've got a question on here. Oh, I've been diagnosed with a lymoma cyst by my GP. Do I need to get a scan privately before I come to you for removal? Good question, Lolly. So that's a very good question. And you know what? Sometimes I put these things on you, clip these up and put them on YouTube. And so, you could say, do I need a scan for my lipoma or cyst? And it's a bit people. I think from the comments, people sometimes get frustrated because the answer is, it depends. And I'm really sorry, but that is the answer. What your best bet is to send us a photo. Send us a photo and we'll have a look. And sometimes we'll see something, and it's often you're not 100% on a photo, but we can give a good idea on a photo, and then maybe have a better idea when we see you and examine you, and we'll have a good idea. Yeah, that feels like a cyst. That's fine. I think we can go to theatre, and I would say the majority of cases, we just examine you and we'll say, yeah, that's a cyst lipoma. We will remove it. But some cases we'll think, is it a cyst? Is it lipoma? One, it might depend on the history. Rapidly growing, painful. Cyst lipomas usually aren't painful, and certainly the area. So, for instance, the forehead, commonplace for cyst lipomas, things like that. You've got to think, what could it be? There's basically skin, and then there's a skull there, and you can kind of tell if it's going to be a skull lump. But if it's not a skull lump, if it's not bony hard, it's under the skin, there's not a lot it could be. So you're going to say, yeah, you're going to remove that. You're going to be kind of less worried about that. But there are certain areas where you might worry, you might want to get a scan, like, for instance, the forehead, fine, but like here, it's called the external angular dermoids here, places like the midline of the spine, kind of over joints. You kind of think, is that just a cyst or a lipoma, or could it be something to do with the joint? Could I, be doing a minor procedure and find that actually it's got a deeper extension? And big things, broadly speaking, big lumps. You kind of think, is that a, lipoma? The other thing is, it depends on where it is on your body. So certain areas, so as I say, the scalp, the forehead is not going to be under scalp. It's not going to be that far, because you've got bone quite close. So you're not going to have it. It's not going to be that deep. But the buttock, the abdomen, maybe the thigh, you've got a light lump. If it's quite indistinct, you can't feel the edges very easily. You've got to think, could this be quite deep? So could this potentially be quite difficult to do under a local anesthetic? So those situations, you might want to get a scan to see how deep it is, because lipomas, you can't really tell clinically how deep they are. Cysts, yes, cysts are usually underneath the skin. So that's one of the differences between the cyst and a lipoma. Cysts are kind of within the skin, but they're just kind of right underneath the skin. And lipomas can be just, quite close to the skin, but lipomas can be anywhere. They can be quite deep. They can be in the muscle. They can be deep to the muscle. And so that can be a bit more difficult to remove if they're quite deep, because particularly under a local anesthetic, you don't really want to be cutting muscle and, going through muscle. Under local anesthetic, that's going to be a little bit more difficult. So those situations where there's potential for a deeper lipoma, then we would want to get a scan first, because we don't want to get into trouble if we're doing a local anesthetic, and we will lightning Q&A. So it kind of depends on where it is. So if we would worry about a deeper extension, we worried it might be something else, like, as I say, associated with a joint or something. Worry about the history, if we think it might be anything, not a lipoma or a cyst, short history, painful, those sorts of features, we might be wanting a scan. But if it's in a quite close to the skin, you can feel it quite easily, and it's in an area where there's not other things, then we might go ahead without a scan. So I'm afraid I can't say yes or no, you'll need a scan. The best thing is send us a photo, WhatsApp it, email it, and we'll say, look, that needs a scan, or we will say that doesn't need a scan, we can go ahead and remove it. So sorry for your question. No, it's a good question, Lolly. Where is it, Lolly? Where are parts of your body? Or maybe you don't want to say on a live on TV, but certain areas you'd be more worried about it, like midline spine. You'd be more neck. You'd be more worried. There's lots of things it could be in the neck. So certain areas you would be a bit more concerned than others. So forehead, yeah, forehead is one of those areas. As long as it's not here, sort of the external angular, if it's kind of forehead, there's less it could be. The only thing about forehead lumps is you've got to be a little bit, well, we would be aware whether if it's bony hard, then it's a little bit more difficult to remove, simply because the instruments we need, because it could be what's called an osteoma. But if it's kind of not hard, and particularly if it's mobile and it's not kind of really big, so it's not like really big, if it's kind of like centimeter, maybe two, there's kind of not that much it could be, so it's probably going to be a lipoma or a cyst. And even sometimes on the forehead they can actually be deep to the frontalis muscle, and even then you can still do it under local anesthetic, although they're a little bit deeper. But so you may well not need a scan if it's on the forehead, but as I say, send us a photo and we'll give you a better idea about that. But no, Lolly, I like questions live. It's good, especially questions I can answer, or at least have a bash at. Do you have to remove a cyst? No, you do not have to remove a cyst. And sometimes people, when people come with a lump, the question is often, what's the problem? And if there's not a problem, and especially with cysts, because cysts can actually be sometimes difficult to see, because obviously they're subcutaneous, they're not the skin often looks normal kind of underneath the skin. They can be quite subtle, and removing a cyst requires an incision with a scar, and so that scar might be more obvious than the cyst. So yeah, sometimes it's a balance. So you absolutely don't have to remove a cyst. So you can leave it. The problem with them is that they can cause issues. They can cause infection. They can grow. They can burst. So they can be problematic. So you might want to consider removing it. But if it's kind of not very visible, if it's not really causing you any problems, you don't have to. Now, if you do leave it and it causes you problems, if it gets infected, we would not be able to remove it while it's infected. You would have to wait for that infection to settle, but then we could certainly remove it once the infection settled. They are a little bit more difficult to remove once they've been infected, because there's a little bit more scar tissue around them, because you've got to get them out complete, otherwise they can come back again. So when it's been infected, sometimes the edges aren't quite as easy to see and delineate, so a little bit more risk of leaving a little bit behind, which could cause a recurrence. So, but still, if it's certainly not a sort of compulsory, if you're really don't want to have a scar, and who does want to have a scar? No one really. If it doesn't really bother you, and no, you don't have to have it removed. And certainly if it's kind of quite new, you might want to leave it and see what happens. And then if it does cause you bother, you might be more accepting of a scar, because you're like, this is really annoying and it's don't like it. But if it doesn't cause you bother, then it doesn't it's not harmful. It's not harmful to have a cyst, in terms of it's not going to do anything, except for the fact that it might get infected and it might cause problems. That's going to be a nuisance, but I wouldn't say that's harmful. That might be a nuisance, but it's fine to leave it if you don't want to have it removed, then it's not too much of a problem. So you do not have to remove a cyst. I've got something on here. Sorry, it's fine. It's soft and squishy, but right by my temple makes me look like I'm stressed all the time. Thank you. I'll send photos. Yeah, right by your temple. So if it's up here, then that's okay. As I say, the ones we a little bit worry about ones by your eye, especially if it's been there since birth. But on the temple, it's less of a thing. Although there are nerves up there we've got to be aware of, but you know, actual removing of it, you know, you can still do it under local anaesthetic, no problem. But yeah, Lolly, send us a photo and we'll have a better idea on that one. Will a mole come back after having it surgically removed? Well, there's two ways to remove a mole. Well, assuming if the mole's flat, if it's a flat mole, there's kind of one way to remove it. You have to cut it out. You cut it out and stitch it up. And we usually cut it out with a very minimal margin. So most moles are benign, and so we're trying to give you best cosmetic results, and the best cosmetic result is obviously a smaller scar, and the smaller scar means the smaller the margin. So you try and remove them completely, but you don't want a big kind of margin around the outside of the mole. You want to get really close to the edges of the mole to make sure you remove what you can see. So we often use magnification and what have you, but you know, you remove what we can see. And if you're removing what you can see, we then send it off for histology. Sometimes it says that it's up to the edges, what they might say is an incomplete excision. Now it might actually be complete, but it's just up to the edge. But if they can't see a clear area around the outside, they might say it's not completely excised. Now, if it's kind of like a mole and it's benign, we will probably say, well, it doesn't matter because it's benign. But you might say, well, there might be some left behind. The thing about moles is if you left that mole there, it probably wouldn't grow significantly for the rest of your life. So if you remove the majority of it and leave a tiny little bit that you can't even see with the naked eye, it kind of doesn't matter. So with an excision, pretty much no, they don't really come back again with an excision. The other option, if it's clinically benign, so if we think it's benign and it's raised, so if it's raised above the skin, there is an option for a shave, which means just taking the bit that's above the skin. And that's a good option because the scar is not quite so bad. But some people worry because they say, hold on a minute, it could come back because you're only removing the bit that's above the skin. Reasonable suggestion. If that's a worry to you, then you can have an excision. You know, it's fine. The benefit of an excision is it is, you know, pretty, you know, usually completely removed. To say sometimes they say it's incomplete, but we don't tend to worry about that. There's nothing to see with the naked eye. So an excision has that benefit, but the scarring is a bit more obvious with an excision because it's kind of like a line, whereas a shave excision, the scarring is less obvious. But people do say, hold on a minute, you're just moving a bit above the skin, there's still stuff left underneath. And yeah, there is still stuff left underneath. But as I say, usually benign moles don't really grow significantly, and you know, it probably won't grow significantly and it'll probably be fine. Now you might say, what do you mean probably? And I'll be like, yeah, well, oh my God, my mum's phoning. Right. Oh, God, I bet, you know what, I bet that's messed up the audio on Instagram. Sorry, has the audio gone on Instagram? Sorry, that was my mum phoning. Come on, mum, you should know I'm a social media influencer and I do a Q&A every Tuesday at 7. So she's obviously not following me, is she, on Instagram? So yeah, people do worry about shave excisions, but I always say to people, look, if it comes back, I'll do it again. And but it's unlikely because, as I say, if you left that raised mole, given that it's a benign thing, it doesn't normally get much bigger over the years. So just if you take the top off, it usually doesn't grow back. But could it? Yeah, it could after a shave. After a formal excision, less likely. But either way, it's not a big problem. We do a lot of mole removal. We do a lot of shave excisions. I can't remember having to redo one, but they're probably, well, I sometimes have to redo it if I haven't shaved enough. So I do have to, people writing in saying you have to redo mine. Yeah, well, sometimes I do have to redo it if I haven't done enough, but I can't remember anyone who it's like kind of fine to start with, and then a few years later they come back and say it's grown back. Never seen that, but it's probably happened in the world. So it probably has happened. It wouldn't be like outside the realms of possibility, but it's not common. So I still think shave is a good thing to do. But as I say, if you're particularly worried about that, then a formal excision would be a way around that. Oh, hold on a minute. What's going on here? Laszlo's got a question. Hi there. I have some lipomas, some around my abdomen, one on my forearm, one on my back is like under my ribs, like 2 centimeters. They made an ultrasound scan in October and they said it's just lipoma. I think that is. I remember you even replied to me and said that it's good news. It makes me discomfort and a little pain when it's under pressure. For example, when I'm sitting on the bus or a chair size of a pea. What is your suggestion about that, doctor? Everyone is telling me to wait and don't jump into an operation too quickly. Right, Laszlo, my opinion on that is, yeah, I mean, it's good news that you've had a scan. Well done. The scan is reassuring because that is good, but it's kind of like, it's up to you, Laszlo. Lipomas are common. They can sometimes be uncomfortable. Unusual for one the size of a pea to be uncomfortable because that's quite small. But anyway, they're relatively easy to remove, Laszlo, depending on how deep they are. But the deeper ones are more difficult to remove, but the deeper ones are also less likely to cause problems because they're deeper. So the ones that cause problems are the ones that are more superficial because you can feel them. Because kind of like if you can't feel them, they're going to be difficult to remove, but at the same time, you can't feel them. So it kind of works well in that respect. The ones that are more uncomfortable are usually easier to remove because they're closer to the skin. So if you can kind of feel it, then it should be, relatively easy to remove. I mean, the downside is that you have a scar over it, but often with lipoma, especially small ones, we can try and make little stab incisions and kind of squeeze it out. So the scarring is often not too bad. But if you've got some, so if you've got multiple lipomas, you've got to think of the cosmetic consequences. Now, at the moment, they're causing you discomfort. So you might say, well, it's discomfort that I want to get rid of, but you will have a cosmetic consequences of scars, especially if they're multiple. You'll have like multiple stabs where we've removed them. And so that'll have a cosmetic effect that you might not like. So it's to balance that against the fact that you've got a lump. It's in the fatty layer. That's what they told me on the scan. Well, that's good if it's in the fatty layer, so subcutaneous, kind of underneath the skin. That's good, as opposed to in the muscle or deep to the muscle. As I say, if it was in the muscle or deep to the muscle, it would probably be hard to feel. So it's good news that it's in the fatty layer, especially if it's just underneath the skin. And if you can feel it, again, that's good news. So if you can feel it, that means it's easier for us to remove. If you kind of, when people present with if they've had a scan that showed a lipoma that you can't feel, that's when you run into trouble, because when you do the surgery, you've got it. They're hard to find. But when you can feel them, then you know what you're doing, and then the surgery's an awful lot easier. So it's over to you, Laszlo. If you've had a scan, if you've obviously seen a doctor to get a scan, they're reassured that it's a benign thing, a lipoma, and nothing to worry about. A bit like the cyst thing, nothing to worry about. Nothing. They don't have to be removed. However, having said that, they are often relatively easy to remove. The removal of it is usually a relatively minor procedure, local anesthetic, walking in and out. It's a bit like going to the dentist, but they will give you little scars where the lipomas are. So you'd have to be happy with that, because often, cosmetically speaking, they're often quite hard to see the lipoma. So your abdomen or your back, or wherever they are, probably looks fine. So if you have them removed, you'll have scars in the area, which will be obvious to start off with and then fade. But is that better than lipomas? Well, it depends on how much bother they're giving you. I think at the end of the day, it's only you that can answer it, Laszlo, whether there are sufficient bother to have them removed. But it's optional. But thank you. That's good number of comments from you, Laszlo. There, very grateful for that. Always grateful for a bit of commenting on the old Q&A. So there you go. I'm out of questions. I've got my mum to phone back. So hope that has been helpful. If you've got any questions, call me, message me, email me, or whatever you want to do. And if you're lucky, no guarantees, but if you're lucky, you could make it on next Tuesday's show. So yeah, I'm going to just educate my mother that I do a live Q&A on a Tuesday night. It is Tuesday, isn't it? Yeah. Hold on, Laszlo's back at me. It is Tuesday, yeah. What's Laszlo got? Laszlo's got, I just had an adrenal ectomy 4 months ago, and it was benign pheochromocytoma. I thought it because they have to remove my right adrenal gland. Do you think can be a cause? Thank you for your answers, sir. You're very welcome, Laszlo. Thank you for your questions. No, I mean, a pheochromocytoma is kind of, obviously, as you know, it's an adrenal tumor inside your body. Doesn't it secrete adrenaline? I think causes blood pressure problems. I don't think it causes lipomas. So I would say that's not relevant. I would say that is just coincidental. Maybe your doctors who removed your pheochromocytoma might know more about it, because they obviously do a lot of that. I do a lot of lipoma removal, but I don't know much about pheochromocytomas. But I do know that they are, I believe, adrenaline secreting tumors, which can, as I say, cause high blood pressure. But I don't think they can cause lipomas. I mean, it's good if you've had it removed, especially because if you have got high blood pressure, you're more likely to bleed, which is an issue in terms of having surgery. But this is all subcutaneous surgery, it's all skin surgery, so it's not really a big issue for this sort of surgery. It might be more for other sorts of surgery. So yeah, I don't think there's a link there myself. But yeah, this will be relatively minor compared to that operation, I would imagine. Yeah, in my family, you have lipomas, father, auntie. Yeah, it's often the way. When you have multiple lipomas, Laszlo, it often runs in families. So some people just have one, which can be just, out of the blue. But people have multiple, it often runs in families. And in those circumstances, sometimes when you do the surgery, you find that there's others. You're doing some and there's others. So you end up, just because you're not really curing you of the problem, it might be that you have multiple lipomas. We're just trying to treat the ones that are symptomatic. So we really kind of rely on you to say, look, these are a nuisance. These ones I would like to remove, rather than trying to get rid of all of them, because if you can't feel them, you can't see them, they're causing issues. Doesn't matter really that you've got them. So we try and limit what we do, rather than trying to go through your whole body and remove them all, because they sometimes are multiple in those circumstances. So yeah, good. That's very good. Thank you, Laszlo, and all my other viewers. Nice to see everyone here tonight. And I'll be back next week. Sorry, don't want to hold you up. Not at all, Laszlo. That's what I'm doing here. That's the whole point of me being here, Laszlo. People like you answering your questions. So don't have to be sorry. I'm grateful to you for engaging. It's good to have a bit of engagement sometimes. Makes you feel like you're sort of, being useful. It's kind of the idea, really, trying to be useful. So yeah, thanks, Laszlo. And if you want any help, or if you want to send us photos, you can. As I say, sometimes they don't show up well on photos to you today, but yeah, up to you whether you have them removed or not. I will. Thank you for that. So yeah, see you next